stop me at any time and then you can ask a question. You can just unmute yourself and ask a question. It's all right. Okay. I would rather encourage that. All right. Just can you just drop in the chat box which of these is a disaster? What do you think is a disaster in these options given to you? A building collapsing with 20 injuries, an LPG blast in a market, an oxygen supply failure, bus accident with 20 injuries, or in your casualty, there's just an unfortunate fire. Okay. I hope you answered all. Yeah. So from this, can you figure out what a disaster means actually? You know, we say something is disastrous when things go out of our hands, isn't it? So that's exactly the definition of disaster. Any event, for that matter, which overwhelms the resources. Let's say in this first scenario, building collapse with 20 injuries. You are in a tertiary care setup. Luckily, you did not have any patients that day, and 3 consultants, 6 juniors are on duty. You think you can't handle 20 injuries, and every orthopedician, anesthetist, everybody's on the floor. That won't be a disaster for you. Yeah, things are still in hands. You have resources to address them equally based on their severity of injury. So disaster is something where these resources are overwhelmed. You can get sometimes only 5 patients for that matter, and then all require an airway securing, and then you just have like 1 or 2 laryngoscopes working. That will still be considered as a disaster because demand is overwhelming your supply there. Okay. So with this definition, let's go ahead further. Okay. Just a brief classification before I go into the depths of this topic. So it's well, we have natural disasters, which, you can see I just put a picture of a tsunami there, and then you have man-made disasters earlier. Terrorist disasters were considered man-made disasters, but somehow they just segregated it separately. Man-made are just, we'd rather call them accidents, like, chemical spills, explosions in factories or road traffic accidents, all these things, train derailments, that Air India flight, that was a man-made disaster, right? Terrorist events are something which are, planned with an intention to cause casualties, like the 9/11 blast or, the Mumbai terror attacks or whatever it might be. So this internal and external disaster confine specifically to hospitals. You can see the picture here. This is actually a real image taken where a ventilator was, ventilator got blasted out and it set a fire in the ICU in that particular thing, right? I'm sorry. So that's an internal disaster. Your hospital itself is facing an internal disaster. Now, where did I place this particular diagram here? This man is Mr. Ghulam Nabi Azad, and he is admitted in a hospital recently after the Operation Sindoor. And then, politicians, the Chief Minister of Punjab is there, Mr. Owaisi is there. What do you think will happen when such people visit the hospital or when such patients are being catered to? Don't you think the entire hospital will move behind them? It happens, right? So when an influential person, even this can be considered a disaster if it is affecting your care or if it's affecting the care of other patients, right? So influential people running into your EDs, this happens all the time, isn't it? So even that can be considered a disaster if the impact is as severe. And there are acute and non-acute disasters. Acute is something which where you feel the impact immediately. Like, whatever examples I gave just now, all of them are acute disasters. Non-acute is something like COVID. It happens slowly and you feel the impact not just there, but then the impact spreads over, months to sometimes years also. So this is just a brief classification of disasters. Now let's go into the topic per se. So, see, this cycle of disaster is the crux of this topic. All right. So when you have a disaster right there, this is the epicenter of the disaster. What happens after that? You respond to the disaster, whether it's an adequate response or not, leave it for now. But you respond to the disaster, you recover, and then if you don't do anything between recovery and disaster, that will again be another disaster with the response, isn't it? So mitigation is nothing but, preventing, and preparedness. Both of them earlier used to be, mentioned separately. It was called PPRR prevention, preparedness, response, and recovery. But now mitigation and preparedness are grouped together in one unit called ready. It's like triple R, just remember RRR, ready, response, and recovery phases. All right. So in this ready phase, how can you reduce the risk? Anybody can just unmute and answer this. How can you reduce the risk of a disaster? Can you do that? Can you just, I don't know, call up God and ask him to tone down the earthquakes Richter scale? You can unmute yourself and speak. How can you mitigate a disaster? Any idea? For some reason I'm unable to see the chat box from my screen, so you can just unmute yourself and talk if anybody wants to. All right.
Mock drills, we can have mock drills.
Okay, mock drills, you can prepare for a disaster. Very good. Yeah. But how do you reduce the risk of a disaster? In the sense that you're prepared the same, but then you feel the impact very less with this mitigation. So we'll move on and you'll understand in the next scenario. Okay. So this is the most important aspect of any disaster preparedness, which is called hazard vulnerability analysis. You've got to know what your hazards are and where you're vulnerable. Okay. I'll try to just point with my pencil somehow. Okay. All right. Sorry. Okay. You can see this is a hazard vulnerability chart or a design you can have in your hospital or wherever. What you can notice here is, see, there are, if you can go through the rows, not the columns, the rows, you have all the types of disasters here that you can expect. It says mass casualty trauma, mass casualty infectious, medical, terrorism, VIPs, infant abduction, all these things. And then in the columns, you can see what is the impact. How much impact can you expect? Like, let's say, see, I'm right now in Seattle, west coast of the USA. Within 100 miles, I have a dormant volcano. It can erupt anytime. You never know. So that's my or this locality's hazard vulnerability. If you're sitting in northeastern part of India, you can expect earthquakes, isn't it? That's your hazard vulnerability. If you're in the southern parts of India, you can expect heat strokes, you can expect floods, you can expect sometimes tsunamis. Yeah, so these are your hazard vulnerabilities. And then you chart them out. How much impact do you face them? Okay, and then if you see the green columns here, if you see the green columns here, you can see that how much prepared you are, how much response you can tackle, yeah, and how much external support will be there. Okay, with this hazard vulnerability, though you may not mitigate the intensity or magnitude of a disaster, but what reaches you can be reduced. Okay, so this is where you reduce the risk of the disaster altogether reaching you. So this depends on place to place, region to region, and what's more prevalent in your locality, in your hospital. If let's say you're sitting in Ames Trauma Center, you expect more of political people coming in. Yeah. So this is all your hazard vulnerability, and then you chart it out and then you analyze them. Okay. Very few hospitals do it, but if your hospital is doing this, that's amazing. Okay. Then we have what is absolutely response. Now, honestly, tell me how many of you are the first responders in a disaster? Like go to the field and then rescue them there. Very unlikely, right? Especially in India. To be honest, I haven't seen ER doctors as such going into the sites and fields of disaster response because we have a very powerful ground force called National Disaster Response Force. Okay, so basically, going down the hierarchy, we have National Disaster Management Authority. It's basically the think tank of all the disaster management in India. It's chaired by the Prime Minister himself, and it deals with policy making and strategy. It is the think tank. So it sits at the apex and frames policies. And then the groundwork is done by National Disaster Response Force, NDRF. You might have seen those vehicles. This includes the Border Security Force, the CRPF. These are all the ground personnel where they primarily respond to a disaster call. They're concerned with rescue and relief. And You have Ministry of Health and Family Welfare, and then you have National Center for Disease Control, NCDC, which comes under MOHFW. So this authority mainly deals with, the medical response to a disaster and disease control. Something like COVID, you would not expect NDRF to respond as much as MOHFW, in framing policies and all. And then, for other natural disasters, you have Indian Meteorological Department, which gives weather warnings, and then you have water commissions, and then you have armed forces, which deals with, let's say you're stuck in an avalanche, or in a, I don't know, unreachable terrain where you have to drop down with a helicopter or a chopper, and then you have to be airlifted out. See, such things armed forces are trained to deal with. And then locally you have your civil defense, which includes your police, and then you have private NGOs working together. So why did I mention all this? Because you need to integrate with them when you're dealing with disaster response. You cannot sit in a hospital and expect, just read up theory and then expect things to fall in place. It doesn't happen that way. But as an emergency doctor, you mostly deal with NDRF, MOHFW if it's a chemical or a infectious disaster, and then you just keep updating yourself with other organizations. And then of course you work closely with civil defense and NGOs also, depending on the place you're working in. All right, now training, like you answered earlier, training is the most important, if I can say, the only important part of disaster preparedness. We've seen when Operation Sindoor was happening, how mock drills were conducted everywhere, and then training doesn't just include mock drills, it includes simulations. It also includes community training, isn't it? See, a community better prepared to tackle a disaster has more survivors. Don't you think so? Somebody rather than, somebody who doesn't just expect it, who doesn't know how to hide under a table when building is collapsing, something like that. The casualties can be mitigated with community training. This can be often neglected, but it is as much important. And why I'm telling this here is we should be the leaders of community training also. Okay. And then courses, courses like this, like what you're attending right now. I might have attended some course, I might have attended ATLS or PHTLS, and then I will learn from there. So then you keep on repeating these. So this is where you acquire the skill, And if you ask me, uh, you can only train or prepare during peacetime. You don't build a fire station when there is a fire, isn't it? You build a fire station before there's a fire and anticipate it at any time. You need to be ready to tackle it at any time, because disasters doesn't come announcing. Very rarely they do. Yeah. So this in peacetime is where you prepare and where you train. And simulations, I think that's one of the best inventions of medicine, because that brings you so much closer to being a god one day, because that training can be the difference between saving a life or, you know, just losing it right in front of you. So not enough emphasis can be put on this simulations and mock drills. And as per Joint Commission's recommendations, you need to at least undergo 2 trainings a year, 2 mock drills a year. We recently had one where I was working back in AIG hospitals. So at least twice a year, you need to conduct these mock drills, look at the debriefing, and then take the feedback, and then keep improving on it. Yeah. So that's how training is important. Okay, let me give you a scenario. You can see here, there is a bomb blast nearby that you just heard of. You're in the ED. So I just asked you, what do you do now? There can be many answers, but my question here is specific. You have 50 patients being brought in 60 minutes. Within 1 hour, you're getting 50 patients. And you have a bed capacity of 60, out of which 40 are full, because you're lucky that day, maybe, or maybe not. Because when does ED have those many empty beds? Okay. So what do you do now? Just unmute yourself and answer. You can just wing it. You just have 20 beds empty, and then you have 50 patients coming in, not to mention other emergencies that may come in. What do you do now? Do you discharge all these 40 patients, or what do you do? Anybody can just unmute yourself and answer. If you're writing in the chat box, I cannot see the chat box right now while I'm sharing my screen. So I really would recommend you to unmute yourself and answer. Okay. I hope you guys were thinking, if you guys were thinking you have to increase your bed capacity somehow, pull up some beds from somewhere, do something with this existing patients in your hospital, not just in your ED, then you're spot on. You're right. That's what we call as surge capacity of the hospital. Okay. Surge is nothing but an abrupt increase. So hospital surge capacity, how can your hospital accommodate this surge is called hospital surge capacity. So remember it with four S's.
Your voice is
First S
breaking.
is it is what I'm doing. Just give me a minute. How about now? Is it clear now?
Yeah, clear, clear.
Okay, all right. So yeah, so we are at hospital surge capacity, and as you can see, we have four S's here. You can easily remember this. But if I ask surge capacity, most of you will first answer it as, just staff and I'm so sorry. Just staff and structure. Okay. But most important thing apart from staff and structure is to have adequate systems also in play. Okay. Systems, because I'll come to that. I'll start with systems first, because communications, trash protocols, let's say you set up so many empty, you have adequate space outside your hospital. You set up some field tents, extra beds, even in the corridors, even in the parking lot. But what if you don't have any communication tools? You don't have any phones, no satellite phones, no two-way radios, nothing. What do you do then? Whom would you position there? And the staff, let's say, who's positioned in these outside, outside your ED, and they don't know anything about trash protocols or how to deal with stuff. What do you do then? So your systems is as important as the rest of the three S's. So staff can include, extra doctors. You can, doctors who are on leaves, they can come back, they can be called back. Who are in other departments can come down and help you. uh, Nurses who are off shift might have to come back. You can increase paramedics, and very rarely you might have to engage non-medical staff also to deal with medical stuff. you know that's usually a catastrophic level of surge capacity. We'll see that in the next slide. But then you just need to make do with whatever you have. Okay. And then structure, you can include your waiting areas. You need to convert them into wards. You can use your parking lobbies, field tents, everything, set up anywhere to provide care. Hospital surge capacity is not just to increase space. It is the ability or to be more flexible and efficient in providing an expanded care. I'm going to repeat this. Hospital surge capacity is not just, putting more beds everywhere. It's about being more efficient and flexible to provide an expanded care. Okay. And then you need stuff. What does stuff mean? That's your resources, stretchers or IV lines, the IV stands, oxygen, gauze pads, medications, whatever, or your personal protective equipment also. All this stuff. So this surge capacity doesn't just mean staff and structure. It includes everything. How much can you handle extra stuff? That's it. That's what hospital surge capacity is about. Just okay. Uh, okay. So, WHO subtly tells about levels of surge capacity. They classify it with four C's. Conventional surge capacity, I think a busy ED in India is always running at surge capacity, isn't it? Uh, I mean, there are rarely occasions where you have empty beds lying there. You mostly have patients lying in the corridors or lying outside your doctor rooms or somewhere. Yeah. So that is a conventional capacity because you're still not compromising much on the care. You're giving resources, you're allocating resources, and you're providing the same level of care to all. So what happens here? It's a conventional surge capacity. You're still running at your surge capacity, but it is still conventional. The next stage is called contingency, where the number of patients increase. So this is where you'll have to use, more. You might have to use recovery rooms. You might have to use ICUs, get patients shifted. You might have to use, post-op wards to shift normal cases to. Okay, so this is contingency. You can still manage. You can still manage, but you'll have to move a lot of things around. And then comes the crisis. As the name itself suggests, crisis is where You're even operating in hallways or tents. Tents means, you have empty space outside your hospitals, and then you set up a field tent over there, and then you have no other option but to operate there. Maybe do a damage control surgeries in this tents and hallways itself, because you ran out of OTs. So this is crisis. And then you have the last stage, as the name says, it is catastrophic. This is where you'll have to involve non-specialists or non-medicos to deliver the care. What to do? See, a layman can understand. Somebody is bleeding. What to do? You just have to apply pressure. He's not a doctor, but he's still providing care, some form of care. Better than nothing. Yeah. So this is a catastrophic level of surge capacity you can expect. So again, all this will depend on the type of disaster, number of casualties, how prepared you are, how much surge capacity is left in your hospital. And this is where you'll decide if you think you're slipping into crisis or catastrophic. That's when you'll have to delegate with other hospitals and start pushing patients out. Okay. So this is about surge capacity of the hospital. Then comes one of my favorite and the most important aspect of any mass casualty or a disaster thing, incident command system. I'm going to go in detail with this. Let me just point out the components of it first. Okay. All right. First, you have somebody called an incident commander. All right. And then he deals with 4 people. As you can see in the bottommost section, first is finance and administration, somebody who deals with logistics, and then operations, and then planning. Between this incident commander has to deal with safety officer, liaisons officer, and public information officer. Okay. This may be confusing. Let me just go to another window and show you a small explanation here. Okay. A small example where let's take your own hospital. I hope the screen is visible. So let's say you have a disaster here. Okay. You have a disaster here. And most often than not, it's your HOD or somebody higher up who receives the call. And then he or she takes up the de facto incident commander thing. Now, as a resident or on the floor doctor, what do? You deal with this. You deal with triage. Yeah. You triage the patients and you keep doing interventions. That means treatment, and then you provide first aid, you do decontamination. So whatever operations are being done on the field, okay, this is included in operations part, right? And then after that, you have somebody who is dealing with planning how these operations are executed and where they are executed and how they are executed. So somebody who's assigning areas where the patient should move next, somebody who's dealing with the beds, somebody who's dealing with documentation, somebody who's dealing with the surge capacity in assessing the surge capacity and in creating the surge capacity. So we have somebody who's doing planning. Yeah. Somebody who's doing operations or doing interventions on the field, and somebody who's doing planning. And then there should be somebody else who should be dealing with the procuring your disaster equipment like drugs, medical supply unit, who's dealing with food and water, and who is most importantly dealing with communications. Yeah, we'll see about communications in the coming slides. But see, the somebody who's not planning but who's facilitating that planning. Yeah. So he's somebody who's dealing with logistics in managing this incident. And then finally, nothing comes without money. Yeah. Who can procure drugs and all without any finances left? So this is where, somebody who deals with insurance and claims, because patients still will have some insurance, some disaster insurance, something. So somebody who deals with that, and then somebody who provides financial aids and legal support also. So he's dealing with finance and administration, isn't it? Finance and administration. So there you go. You have operations, planning, logistics, and finance. I used to remember it like flop, because if you don't take care of this 4 steps properly, your mass casualty incident is going to be a flop. That's how you can remember. So these guys are dealing with their own stuff, but somebody has to delegate with them constantly, and that person will be your incident commander. So we have that person being your incident commander. All right. So dealing with this and delegating with this incident commander also has to deal with somebody who's taking care of public information. Because let's say the bomb blast scenario, 50 patients were coming in. Now, do you think they just come in alone? What about friends, families who heard about it on the news? Won't they come running to the hospitals to see their kith and kin? Let's take 2 for each patient. How many would that be? 100 people wanting to know what happened. And then you have media. You'll have to deal with the media also in the hospital while dealing with this emergency. So this public information, there will be a public information officer specifically, and that person deals with the incident commander directly without disturbing these operations here. Understood? And then you have safety officer. You can't let anybody in, and then there are some protocols to be followed. You cordon off some areas, and then you need somebody to take care of it, to see a proper flow and to see the safety of the doctors, the patients, and even the relatives as well. Yeah. And so that person will be a safety officer, and he directly deals with the incident commander. And then liaisons is nothing but communications. You might have to communicate with various other people, like we said, dealing with other responders like firemen, police, the National Disaster Response Force, or NGOs who's coming in to support, who's trying to donate to the hospital. They do, right? Good Samaritans come up. So that's what you do. So incident commander, while dealing with all this, he oversees the functioning of FLOP, finance and admin, logistics, operations and planning. So I hope incident command system is simple. And the beauty of it is, this doesn't need to be just in a hospital. You can set it up immediately anywhere. Incident commander doesn't need to be HOD just because I mentioned it. It can be you as well. Okay. All you need to do is you need to know your assigned role and then stick to it. That's it. You can be an incident commander, but you should not slip into operations. You need to have somebody doing the operations there, because if you jump into this, these will be compromised. Understood? So stick to your roles, and then anybody can be an incident commander. Anybody can be in anything based on your capabilities. So it can be set up anywhere in any scenario. That's the beauty of incident command system. All right. So that's what has been explained here. And then, so now comes the response part. We have talked about mitigation part. We have talked about preparedness part. Now comes the response part. So these things I'm not going into much details, because triage and everything has been dealt with, I hope, in much detail. And then you can find them better in textbooks than my voice also. See, again, disaster triage, there are so many triage systems existing for you to classify patients, whom to see first, whom to attend first, what to treat first, how to categorize. So what I suggest here is stick to one triage system and master it. You cannot, read everything and be a master of everything without applying them. Stick to one thing, because all will work the same as long as your intent is right. This is taken from ATLS 11th edition. So you all know this. Immediate will be red, delayed is yellow, minimal is green. Expectant is somebody where, he may die or he may not die. So you give him some comfort medications, or give him or her some comfort medications, and you expect him to come back. If he's not coming back, and then he drops to black. That's it. And then you have a start algorithm. I'm not going to details of this. And then you have jump start algorithm for pediatrics. The only difference is you give extra 5 breaths here. If you can see, you give 5 rescue breaths if it's a pediatric patient. If it's an adult patient, you just leave him there. So you have start algorithm, you have jump start, and then you have SALT algorithm, SORT, assess, life-saving intervention and treatment. And then you have many other things. You have field triage response, and then you have mass, move, assess, sort, and send, mass triage system. So you have so many triage systems. What I advise is just master one. Just master one, and then keep practicing it, keep implementing it. That is how you can master triage, because the intent is what matters. Triage itself means do maximum good with minimum, resources. That's it. It's not providing best care to one patient. Okay, we are coming into final segments of it. Communications. You see this image there? An earthquake shattering even a communication pole. Do you think cell phones will work at that time? Obviously not. Okay, that's a powerful answer. But though I did not understand that. Okay, cell phones do not work. So if they're working well and good, if you're used to using a cell phone and if they're working in a disaster scenario, it is very well appreciated. But it is advised to load up or to stock up with these, these are called two-way radios. Okay. In colloquial terms, we call them walkie-talkies. They just run on a single bandwidth, and then only the recipient and the talker will receive the signals. So they won't get disrupted with cell towers getting damaged, or, sometimes what happens when disaster happens, they put up jammers, to reduce the uh, communications disturbances. Sometimes it happens. Even in the hospital, they encourage you to not use cell phones and use other mediums. And then these are pagers. Pagers, to be honest, I have seen only once being used. Normally, people won't use pagers that much. And this is called a satellite phone, the small one, because a satellite phone is not like a cell tower. It receives signals directly from the satellite. So is it better than a cell tower? I would say no. But then in a disaster scenario, it works well. That's it. You need to go ahead with what is working for you. And then this message boards. This is one of the important aspect of communications, because you set up a disaster response in your ED, and then nobody knows where the decontamination is set up. Nobody knows where the triage is set up. Nobody knows where the operations are happening. What's the use? So even setting up boards is one form of communication. Okay. And if communication fails, that's it. Your disaster response is havoc. It's wrecked completely. Okay. All right. A quick mention about decontamination. This comes in core disaster response. So I'll just quickly brush over it. So decontamination, remember, it has to happen to all the patients entering ED, irrespective of their triage categories. Okay. Only if it's a dispersed gas that can't be, externally decontaminated, only then you take to ED. But otherwise, decontaminate everyone. You use level C protection. We'll see what it is. And then, they advise at least put the decontamination setup 300 yards away. It's like 100 meters away, right? So from the ED, or from where you're actually doing your operations, interventions, and treatment. Okay. And then this part is important. ED should be upwind. We'll see that in the next slide, so you'll understand it better. And you need to contain the runoff water. See, you can see the hose decontaminating, the water hose and then the jet of the water decontaminating. All this water is now contaminated. It should not run or mix with the routine drainage. Yeah. And then all the recycled water will get contaminated. So this needs to be contained off and then dispersed later in accordance with local guidelines. All right. And then, so this is the levels of protection. Simple to remember, not so much. Level D is not considered medical. We don't deal with level D. So medically, we only deal with A, B, and C. To be honest, medically A, I have never seen anybody using it. It's done when you have, when you're completely contained in a capsule. Even you are attached with a cylinder. The air is an internal circuit, not from outside. And then level B, you have highly purified air coming in, and then you have some amount of oxygen also pumping in. And then level B prevents you from chemical splashes also. Level C is what we use normally, what we have used in COVID times. You have a good respirator with well-functioning filters, and then you are covered from top to bottom, but you're more flexible, and you're breathing room air there, of course, which comes through filters, but still you're breathing room air over there. And then level C is enough for most of the um, disaster operations. Level A and B are sometimes needed, especially in the coming slide, we'll see where it's needed, but level C is where it's required more. Level D doesn't have a respirator. It may or may not have an eye protection also. Level D is for workers, construction workers or somebody, working with cement and all. It's not for us. CBRN event. CBRN is nothing but chemical, biological, radiation, and nuclear events. So this is where you have uh, a disaster which contaminates. Yeah. So you have a central area called the hazard area. This is the epicenter of the disaster. That's where it happened. And let's say the blast has spread, and this is the radius. That is the hot zone. So everybody in that hot zone is considered contaminated. Okay. Surrounding that hot zone, you have a perimeter, and this zone is called warm zone or it's yellow zone. It's a safe place, but this is where your decontamination happens. You can see decon station, right? This is where decontamination happens. Only then the patient is safe to come out. So, which is why we call this cold area called clean area. Now use your common sense and tell me, where should the operations triage, your command post should be set up in? It can't be somewhere where it's getting contaminated, isn't it? It has to be in the cold zone. So your staging area, your command post, all the setup will be in the cold zone. And notice this part. This is the utmost important part here. The wind direction. It doesn't make sense if the wind is coming this way. Yeah. Whatever you're decontaminating, if the wind is carrying all the way to cold zone, what's the use then? So whatever you are setting up, the wind has to move in this direction. I'm sorry about the mess, but had to do that to explain. All right. So, yeah, the wind direction should be towards the hot zone, away from the command post. This is what I mentioned by ED should be upwind. It should not be downwind. Understood? So the wind should carry, if at all any contaminated is still left, it has to carry into the contaminated zone, not outside the contaminated zone, right? This is for a CBRN event. Okay, we are about to conclude now. Let us see how ready you are, okay, in managing disaster. So we are concluding. This is the last slide before the references. So let's just, how many of you assign 1 point to each of them, and then just you mentally calculate how well you are, how ready you are. Do you know what your hospital's disaster code is? Does it have a code for it? Our hospital has something called code orange. That means mass casualty happening. Does your hospital have any disaster action plan, or are you aware of it, or it doesn't? And then, have you attended any disaster drill in the past 6 months? How well you know START or SALT triage or any triage algorithm or triage system for that matter? And then, do you know who your incident commander is? Or do you know at least how to set up an incident commander, or who can become an incident commander if a disaster comes? And then, how confident are you having managed at least 5 critical trauma patients? If you assign 1 point to each, and then if you think you're ready, oh, I'm sorry about it. Okay, if you think you're it, sorry, if your score is between, so sorry again, if your score is between 4 to 5, if your score is between 4 to 5, I think you're ready to handle a disaster. You're really ready to handle a disaster. If it's less than that, you need to prepare. 0 to 1, I'm sorry, hopeless. You need to start from scratch. Okay, I haven't prepared this myself. I looked it up online. I found a really good poll here, and then I thought it will be nice to just give you an idea of how good you are in managing a disaster. All right. So that concludes the topic, and yeah, it's 40 minutes, and I hope you can take some, you know, um, important points, takeaway points. You have some mantra for your day from where you can build on. Like I said, this is not a complete disaster management course. It's to give you a template or a blueprint to work further on. So these are my references, and I welcome any questions. Thank you so much for your listening, and I hope this was, um, at least of some worth.
Thank you very much, Dr. Sharat. Really enjoyed listening to you. I mean, such a logistical and dry topic. You have incorporated it into medicine, and you have entertained all along. So,
Thank
Dr.
you.
Sharat is also our instructor for the disaster medicine course, which we have conducted last few months ago. So, Dr. Sharat will take some questions if anybody is
Sure,
posting in the
of
chat
course, yeah.
box.
We have, okay.
So there's
Okay, any questions, guys? I'm glad to take any questions,
So
and I hope
I
I can
just
answer
want
them too.
to, maybe nobody is asking. I'll only ask for one question. As Dr. Sharat is a ATLS instructor also, so just wanted your opinion about the new 11th edition disaster medicine chapter. I feel that they
Mhm.
have removed a lot of the previous disaster
Yes, yes. So, like I said,
material
the
from the
11th, yeah, the 11th edition, it simplified disaster preparedness because what I felt was because they have a pre-hospital trauma life support course also, and I'm guessing that is pulling up its own new edition very soon. And then maybe they are giving in detail in pre-hospital trauma life support. But then again, I would also say that 11th edition still gives you that blueprint to work on, like how I did today, like how I thought I did. So it gives you a blueprint to work on. It covers the important parts like what is disaster, what is mass casualty, what is an incident command system, and then what is the disaster cycle, and then how to handle them, and then the new XABCD protocol. This is all good, but then yeah, it is simplified. I wish I knew the answer why, but it's just what it is, I think.
Yeah, thank you, Dr. Sharat. Really, thanks for taking the time
Thanks for the opportunity, Dr. Nain.
at
I,
5.
I
I
really
can see the
appreciate it.
time in
Yeah.
your screen sharing. Yeah.
Okay.
Yeah, we can see the time in the screen sharing also. It's 5:30 a.m. for you. So really dedicated
Yes.
you are. So okay, we'll
No,
end this
glad
session
to.
now. Thank you. We'll meet next
Okay.
week. Our next week's topic is management of chemical burns by Dr. Nikhil Paul. So we'll meet next week. Thank you very much. Bye.
Thank you all. Have a great day.